Right. Okay, let's try and unpack something that's honestly pretty baffling in heart care. Statins and heart failure. Because when you look at the guidelines, well, they almost seem to contradict themselves right off the bat. And that's where we're going to start this deep dive. So our mission really is to figure out why these drugs are, on one hand, seen as absolutely essential, like class 1 mandatory use if you have heart failure and have already had a heart attack or ACS, for secondary prevention. But then the same guidelines turn around and say, well, don't start them if your only goal is to improve outcomes in stable chronic heart failure with reduced ejection fraction, HF-REF.
Exactly. And, the whole puzzle really centers on this fascinating biological issue we call the lipid paradox.
The lipid paradox.
Yeah. It sounds strange, but in patients with pretty advanced heart failure, studies keep showing that having low cholesterol is actually linked to a worse prognosis.
Worse? Wow.
Right. So that tells us straight away, if statins are going to help these specific patients, it can't be because they're lowering LDL cholesterol. That wouldn't make sense. Any benefit, it has to come from their other actions, the non-lipid lowering ones, what we call pleiotropies.
Pleiotropies, like anti-inflammatory effects.
Very fibrotic.
That kind of thing.
Exactly. Reducing inflammation, maybe helping prevent cell death in the heart muscle, those sorts of things.
Okay, but hang on. If it's all about these other pleiotropic effects, then why didn't those two massive trials, CORONA and GISSI-HF, why didn't they show any benefit? I mean, they were huge trials, right? Thousands of patients.
Well, that's the absolute crux of it, isn't it? The pharmacological detail. You see, both of those big trials used Rosuvastatin.
Rosuvastatin. Okay, and that's a
hydrophilic statin,
right?
Water soluble, and because of its chemistry, it doesn't easily get into peripheral tissues like the heart muscle itself. It needs active transport.
So it doesn't build up much concentration in the heart.
Generally, no. Very low concentrations expected in the myocardium. So if the benefit you're looking for is inside the heart muscle cells, like reducing inflammation there using a hydrophilic drug, well, it kind of puts you at a disadvantage from the start.
So wait, are you saying it wasn't necessarily the idea of using a statin that failed in those trials, but maybe just the type of statin they chose?
That's the leading hypothesis, yeah. The thinking is that the lipophilic statins, the lipid-soluble ones like Atorvastatin, Simvastatin, they're different.
How so?
They can just diffuse passively across cell membranes. So theoretically, they should achieve much higher concentrations right there in the heart tissue.
Making them potentially better for delivering those pleiotropic effects where they're needed.
Precisely. Better suited for the job if the job is tissue-level anti-inflammation or anti-apoptosis. And, we actually see some pretty strong hints supporting this idea when we look at the other main type of heart failure, HFpEF.
Heart failure with preserved ejection fraction.
Yeah. Now, HFpEF is often thought to be heavily driven by systemic inflammation. And what does the observational data show?
Let me guess. A benefit with statins.
A pretty robust one, actually. Observational studies suggest somewhere around a 25% to even 40% lower mortality risk in HFpEF patients on statins.
Wow, that's significant.
It is. And it kind of suggests that maybe this more inflammation-driven condition is responsive to statin pleiotropy. And importantly, in the real world, many of these patients are likely on those more lipophilic agents.
Okay, that makes sense conceptually, but then you hit the clinical reality, right?
Yeah.
Safety. Managing heart failure patients means juggling a lot of medications, polypharmacy.
Exactly. Safety becomes paramount. And while those lipophilic statins might theoretically be better for pleiotropy in the heart tissue, the hydrophilic ones like rosuvastatin and pravastatin, especially the ones that are highly liver selective, are often seen as the safer choice day to day.
Safer because less interaction risk.
That's a huge part of it. Drug interactions. You see, many lipophilic statins, like simvastatin and atorvastatin, are broken down by a specific enzyme system in the liver, CYP3A4.
Okay, CYP3A4, like a busy highway for drug metabolism.
A very busy highway. And the problem is, a lot of other critical life-saving heart failure drugs use that same highway. Think about amiodarone, a common antiarrhythmic.
Right.
Or fibrates like gemfibrozil used for triglycerides. If you give them together with a statin that also heavily relies on CYP3A4,
traffic jam,
big-time traffic jam, the statin levels can shoot up dramatically, and that significantly increases the risk of muscle problems, myopathy, even rhabdomyolysis, which can be very serious.
And regulators warn about this.
Oh, absolutely. There are specific warnings, for instance, about not using simvastatin doses higher than 20 milligrams a day if someone's also taking amiodarone. It requires real vigilance.
Okay, so pulling all this together, what are the key takeaways for you listening to this? It seems like there are two main things. First, if you have heart failure and established vascular disease, like a prior heart attack, statins are still absolutely vital for preventing another event. That hasn't changed.
Correct. Standard secondary prevention, non-negotiable.
But second, when we're talking about using statins to directly treat the heart failure itself, especially HF/EF, the benefit, if there is one, probably isn't about lowering LDL. It's likely more about those pleiotropic effects. And whether you get those effects might really depend on the statin's lipophilicity, its ability to actually get into the heart tissue.
That seems to be where the evidence and the lack of evidence from the big trials points. It strongly suggests the choice of a hydrophilic drug in CORONA and GISSI-HF might be why they came back neutral. We infer, but we don't know for sure.
So what's needed then?
Well, the only way to truly nail this down, to move beyond inference, is a dedicated clinical trial. We need a head-to-head comparison.
Lipophilic versus hydrophilic.
Exactly. Pit a proven lipophilic statin, maybe Atorvastatin, directly against a hydrophilic one, like Rosuvastatin again, specifically in patients with HF/EF. See if tissue penetration really is the key.
And that trial hasn't been done yet.
Nope. Still waiting. That's the definitive study needed to finally resolve this controversy.